To the section of oncology session on robotic surgery in UK urology. And what we're aiming to do today is stimulate a little discussion, or a lot of discussion, about how we make best use of this technology. That discussion can continue on the forum on the BAUS website. I've made a start at it, and the feedback and discussion from all of you will be really important in helping shape BAUS' view on robotics. During the session, we're set up to use the app to ask questions. Jim has an iPad, and as we go, if you would like to ask a question, use the Ask a Question function in the session. We'll take all of the questions at the end as part of the discussion. So just as we go, fire in your questions. The reason we're doing this, I think, is that it's clear that the cost of robotics has the potential to cause conflict. And the costs are primarily associated with the hospital stay and the technology. And we don't know so much about the after-hospital costs, whether they're higher or lower. What I believe is that we must all put our patient first and offer our patients what we would like to have offered to us or our families. But we've got to recognise that we're in a public health funded system, and therefore we must seek to get best value out of the tax pound that pays for our health care. And I think there's a duty for all of us to work towards that, to deliver excellence for our patients at the best possible value for the system. And that responsibility lies with us as clinicians and urologists. It lies with the NHS as the funder, and it lies with the companies who produce and maintain the systems. So we've put together, I think, a very distinguished panel, international experts. The objective is to give an exemplar of each of the commonly performed surgeries in using robotic-assisted technology. First up, Jim Adshead is going to give us a presentation on the current state of robotic surgery in the UK, drawing on the BAUS dataset, which I hope you will contribute. Then we'll move on and look at how robotic technology has allowed the radical prostatectomy operation to be done in a completely different way that would be simply impossible using any other approach. Then partial nephrectomy, and finally cystectomy. So without further ado, I'll get Jim to get us going. Remember to use the app to ask questions as we go, and at the end we'll address those. Thank you.
Thank you very much, Alan. I suppose my conflict of interest here is that I only do robotic surgery. So I'll give you my view on it, but you have to take that with that as the current state. And I've been like that for about 8 years now for all 3 of these procedures. But British urologists have been at the cutting edge of switching open to keyhole surgery in the UK, and we've had a reputation, I think, of pushing that boundary quite safely to benefit our patients. There's no stronger testament to that, to our commitment to improving outcomes than our submission to our national BAUS database. And the data provides robust snapshots for the current picture in the UK, and so far has shown that our NHS outcomes in the data sets that we've published have really been quite outstanding as a surgical group, I think. So urologists have led the field when it comes to robotics worldwide, and we in the UK have played an important and significant role in its evolution. There are many units that are considered amongst the best in Europe for outcomes and volumes. However, there's been some understandable financial pressures that commissioners currently face in cancer treatments, and there have been recent documents from NHS England casting doubt over the future of robotic partial nephrectomy and robotic cystectomy. So why all the fuss about robotics? I think this slide says it in a nutshell, really. Urologists have struggled with the switch to minimally invasive surgery for complex procedures. And if you look at laparoscopic pyeloplasties that were first published in the States in '93, it made no difference to the number of loin incisions that were being performed. And once Robotics was published in 2003, the number of open pyeloplasties tailed off. So essentially the robot is just a bit of kit that makes complex keyhole surgery easier, but at a higher cost and from a monopoly provider at the moment. So the first robot in the UK went into St Mary's in 2004, and I think since then we've had a fairly slow and considered approach to purchasing robots. The switch from laparoscopic to robotic radical prostatectomy has been slow in comparison with the US. And we currently have 40 systems paid for by a mixture of NHS and charitable sources. They're pretty equally spread across England now, not so much across the UK as you can see. And most of them are in urological cancer centres. Some centres are using their robot 2 or 3 times a week, and others are flat out 12 sessions a week and having to buy a second machine. There can be no doubt that they make complex minimally invasive surgery easier, and many robotic cancer centres are achieving results that are comparable with huge volume laparoscopic gurus from around the world. And I believe it would have taken the NHS many years to get to that point on the learning curve without the robot. It's important to note that many units have abandoned laparoscopic surgery for these procedures because they've been doing robotics for almost a decade now. And therefore those hard-earned laparoscopic skills have faded into obscurity in many of the big volume cancer centres. And the switch back to open would possibly be unethical for some procedures, and back to laparoscopy might not even be possible. I'm not going to dwell on the prostatectomy audit too much, as it's not really a focus of a decommissioning proposal, but the numbers of radical prostatectomies are increasing each year, despite active surveillance and other emerging treatments. And in 2014, we had the first mandatory collection of the data, and we got over 7,500 enter into the BAUS database, which is fantastic. We've captured about 79% of the HES English data, and this will increase now that the email reminders are going out, and hopefully we'll get up to that 90% and beyond mark. So what about partial nephrectomy? Well, the BAUS database captured 90% of the HES data, but only 46% of T1A tumours had a partial nephrectomy done. And the reasons for that, I would say, are twofold in my view. The majority of patients and urologists in the UK are faced with the choice of a lap nephrectomy or the morbidity of an open loin incision when they're looking for a treatment for a small renal mass. And the median number from the BAUS database per individual consultant done is 7 cases over 2 years. So the median is around 3 to 4 cases per consultant, which you could argue is a little low. 18% of them were performed robotically over that 2012 and 13 database. And if you look at the number that centres are contributing, the median over 2 years is 13, so approximately 7 a year from a centre. And that came from over 100 centres. So there is a possibility that more centralisation could happen with partial nephrectomy, because that does seem that it hasn't even centralised into the cancer centres completely yet. So across the board, our own UK data suggests that robotic partial is producing outcome improvements in length of stay, margins, all complication rates and blood loss. Of course, we don't know what the Padua, the renal or centrality index scores are for these tumours. We haven't collected that, so we can't match them for complexity. And the other thing I would say is that the robotic surgeons in the group do tend to be the higher volume end group, so you may be comparing low volume open surgeons with high volume robotic surgeons. However, if you match just the lap and the robot ones, they do seem to be comparable on the tumour size and the volume of the surgeons, and yet still the outcomes are appearing to be better. So if we want to switch to doing more minimally invasive partial nephrectomies and less lap nephrectomies for small renal masses, then the robot does appear to be a way to deliver this for the NHS. The case for robotic cystectomy is definitely less clear-cut. The data is very immature, not only internationally, but in the UK certainly. The 2015 data will be mandatory, so we will improve data capture. There's roughly 1,800 cystectomies captured on HES a year, so we're getting closer to capturing much more of them. I sincerely hope that robotic cystectomy isn't the fool guy in this process, as if ever a group of patients need improvements in their outcomes, it's this group. This is, of course, the most morbid procedure done in any of our departments, and the number being performed in the over 80s, according to HES data, has gone up by 160%. In 2014, of the cases submitted, 25% of them were minimally invasive, and 2/3 of those were robotic. And the switch to minimally invasive surgery is aiming to reduce that physiological insult on this group of patients. I don't want to steal Indabir Gill's thunder because I know he's going to talk about robotic cystectomy when he gives his presentation. And I know that he will cover the fact that there are 2 randomised trials now that have shown robotic cystectomy only to be equivalent to open and not superior, apart from blood loss. But they are comparing laparotomy with laparotomy because the reconstruction has been done extracorporally. Once you start performing intracorporeal reconstruction, you do see improvements over open surgery and big reductions in length of stay. And those UK units that are doing intracorporeal reconstruction are now starting to publish their data, but that was not available at the time that NHS England had to look at this before they released their consultation. So I'll finish with this slide. The evidence is emerging in systemic reviews, papers coming now from UK units showing improvements in outcome and reductions in length of stay. The BAUS dataset has demonstrated for robotic partial nephrectomies to be a front runner, and I would urge that we await for the outcome of the 2015 mandatory collection of cystectomy data to see if there are further benefits for this difficult group of patients with robotic cystectomy, especially with intracorporeal reconstruction. So I think there are 3 big questions that I will finish with. How can we optimise the use of the robots that the NHS has already purchased? What's the best way for commissioners to be able to negotiate with monopoly technologies to get the best price for all of us? And how can we as urologists best engage with NHS England to allow the UK to stay cutting edge but also deliver value for money? Thank you very much.